So today's presentation is entitled Privacy and EHR Information Flows in Canada. The speaker is Joan Rock. Joan is the Chief Privacy Strategist at Canada Health InfoWay. She's responsible for ensuring that privacy is being addressed by InfoWay in its work to accelerate the adoption of electronic health records across Canada, and her focus is on information governance in the context of the EHR. On a personal note, Joan has made some, I think, significant contributions to our understanding of sharing, data sharing of personal health information across the country um, through her work and the groups that she chairs at InfoWay. And with that, I will pass it on to Joan.
Well, thank you, Khaled, for the introduction, and good day to everyone, and thanks for joining us this session. When I was thinking about this presentation over the weekend, I really had to laugh because what came to mind was a time in the early 50s when people used to gather around the radio, I remember that, and listen to hockey games, the opera, shows like Howdy Doody. And now we're gathering around our computers and iPhones to listen to these kinds of presentations. So there's a saying in French, when it's translated, it goes something like, the more things change, the more things stay the same. So I hope you find the visual on this as amusing as I did. In any case, we do have a lot of material to cover today because there's been a lot going on in my world over the past years, and I'm really pleased to have this opportunity to share it with you. I also understand that there are a number of people who don't have access to the slides on screen. They are simply listening to the audio through the telephone. So I'm going to try to remember to reference the slide numbers as we move along so that you can follow using whatever medium you have available to view the slides. What we're going to be looking at today is a little bit of background. I don't know who's in the audience, so I do have to spend a couple of minutes talking about the organization that I come from. It's Canada Health InfoWay, and our privacy mandate and work. But I will be spending the better part of the presentation on a common understandings paper that was produced by the Health Information Privacy Group. Khaled mentioned that we sponsor a number of groups at InfoWay. And this is a paper that was produced by that group. So that'd be the lion's share of the presentation. And about 10 or 15 minutes at the end will be left for responding to questions. So on Canada Health InfoWay, it was created in 2001, and over the past 11 years in total, we've received about $2.1 billion in federal funding. I know that sounds like a huge amount of money, but it's a huge initiative that we're undertaking. We're an independent, not-for-profit corporation, and we are directly accountable to the 14 federal, provincial, territorial governments. At the bottom of this slide, you'll see our mission statement, and what we are all about is fostering and accelerating the development and adoption of electronic health records across Canada. They have to have compatible standards and communication technologies to be able to do that. And what's really important here is that in this last sentence, that InfoWay builds on existing initiatives. A number of countries actually, who have undertaken this kind of initiative have chosen a rip and replace kind of approach. And we're not doing that in Canada. We are leveraging existing systems, and that has increased the challenge that we have to face because there are interface issues and integration issues that also have to be considered. And everything that we do is done in a collaborative manner. We are strategic investors with the jurisdictions. We don't build the systems or manage them, and we don't collect data. What we do is we set the overall direction, and we co-invest with the jurisdictions to bring this direction to life. So that's basically Canada Health InfoWay. Our vision is to provide information or make information securely available to authorized users all around the circle of care. And to do so is required to provide safe, effective health care to clients / patients. I'll use the word patients. I know there's some concern about what term we use, but I'll be using patients through the rest of the presentation. And so this vision is nicely illustrated in this slide, I think. You'll see in the center of the slide that there is a patient. There we go. This is the center of all of our activity. And what the slide illustrates is that no one care setting meets all of a patient's health needs. The services are accessed in many places, and as a result, information is collected and stored in many places. So our objective is for the appropriate information to be available to the appropriate service providers at the appropriate time. And of course, our ultimate objective in this whole exercise is increasing patient participation in their care, improving the management of chronic illnesses, improving access to care in remote and rural communities, seeing that there are fewer adverse drug events and better prescribing practices, etc. And I just want to say we have been seeing progress in this. On the screen right now, I have very few examples of some of the recent progress we've noted. There is lots more out there, and I'd really encourage you to go to the Knowing is Better website that InfoWay sponsors, because there are many examples beyond these. So just to spend a little bit of time on these three. Southwestern Ontario launched a diagnostic imaging network across 26 locations, and what that meant was that for the first time, physicians in Southwestern Ontario in near real time now have access to X-rays, scans, MRIs, which originate outside their institution. And it also means that patients don't have to travel to access specialists who are outside of their community. The second example, Sault Ste. Marie, EMR Extra. This is a fabulous example where physicians are now linked with pharmacists through the EMR. And what this does is it allows pharmacists to access the EMR, to view the physician notes, and document on the same chart as the physician. And what this means is that they have better medication coordination, and they have seen a 94% increase in the identification of drug-related problems. Just a huge benefit because, as many of you I'm sure know, many of the problems, adverse drug events, are really a problem in the healthcare system. They're costly in terms of patient life, and they're costly in terms of financial resources. The third example here references our Drug Information Systems report that InfoWay commissioned. Deloitte, I believe, was the company that did this, and the results were really impressive. They showed that investments in drug information systems generated an estimated $436 million in cost savings and efficiencies in 2010 alone. And they have given estimates of what that means over a 10-year period. It's quite dramatic. So the results there as well show increased medication compliance, productivity going up, and adverse drug reactions and medication abuse going down. So these are just some of the examples of the progress that we're already seeing with the system. I'm now on the slide having to do with support for the EHR. And I just wanted to remind everybody that in 2007, InfoWay joined with the Office of the Privacy Commissioner of Canada plus Health Canada to undertake a very large survey focusing on privacy, health information in the EHR, and the public's attitudes towards it. The study showed, and it was an update of a study, a smaller study that was done in 2003. So in 2003, you'll see on the screen that 85% of the Canadian public indicated the support for the EHR. By 2007, that had increased. And I just want to mention that we continue to conduct surveys of this nature and focus groups as well so that we can get a closer touch with the people. And these support numbers are staying the same. As a matter of fact, the Canadian public every often says to us, like, isn't this in place already? So they really see a lot of value in it. At the same time, they do have continued expectations that privacy and security will be addressed. They continue to call and are actually even stronger in their calls for the existence of audit trails and that there be privacy policies and that there be sanctions in place when there is inappropriate use of the system. They have also indicated some acceptance towards secondary uses, particularly when it relates to health research, to public health, and preventing the improper use of the health system. So that's just a bit of background on InfoWay and the initiative in general. I'd now like to sort of change gears and focus on privacy work at InfoWay. This slide illustrates our objective and our mandate. Now, our mandate for privacy is set out in our funding agreements, and basically it's very simple. It basically requires us to achieve our objectives in compliance with applicable privacy laws and to include privacy impact assessments. Now, it's simple, but it's also very challenging, considering the fact that we are a strategic investor and that the jurisdictions are the ones that are responsible for not only healthcare delivery and how healthcare is structured in their province, but also for the approaches that they are going to choose in establishing the EHR initiative within their jurisdictions, and in addition to that, their privacy approach. So this next slide, and I'm not going to go through all of the individual parts of the bars on this slide, but it just illustrates the extent to which we have privacy or health information law coverage in Canada. So when our mandate says that we have to achieve our objective in compliance with all applicable privacy laws, you can see that it's a tall order that we're facing. And the next slide illustrates how we have managed to achieve that. Basically, we've taken a privacy by design approach. I'm sure everybody's heard that catchphrase over the past year. And we basically adopted this in the early 2000s, well before that phrase actually became popular. We were reinforcing the message that privacy had to be considered right at the outset of an EHR initiative. We couldn't afford to have it as an afterthought. It had to be built in. So the elements of our privacy program include incorporating a privacy and security component to the whole EHR architecture, the requirement that there be privacy impact assessments undertaken in every project that involves personal health information and for which we co-invest. We also contribute to legislative and policy initiatives to encourage jurisdictions to consider, what might be coming down the pike in terms of trans-jurisdictional data flows, and to ensure that the new kinds of entities or organizations that are cropping up are properly authorized in the existing or new legislation. We get involved in a lot of external activities, which I'm not going to take time to go into. We undertake specific projects. We've had one on interjurisdictional data flow. We're currently sponsoring one having to do with consent directives management. We also prepare a lot of papers and reports on EHR privacy issues. We've undertaken a privacy impact assessment of the blueprint. The two items that are highlighted in orange, or whatever colors on your screen, the white paper on information governance and the common understandings paper are the two that I'm going to focus on in this presentation, so I won't say more at this time. And we also host a number of forums, the Pan-Canadian Privacy Forum, Health Information Privacy Group. I'll spend more time on that. And I'm on slide 12 now. Okay.
You could just start that again.
All right. I apologize about that. The whole system dropped here. Anyways, looks like we're rebooted. So what I'm doing now is providing you with a little bit of background on how the Common Understandings paper came to life. In 2005, the Privacy Security Conceptual Architecture, which actually sets out the features that a system going to be privacy sensitive and secure needs to include and covers things like encryption, identity management, de-identification. That document, buried in the back in Chapter 10, included reference to something called governance. And there it ended. Nobody paid particular attention to that chapter. In 2007, however, we concluded that this was an incredibly important area because what it did was to address the rules that needed to be in place in a non-technical way to support all of the information rules of the road, basically. So what we did was we pulled together a white paper on information governance that basically was intended to explain what our understanding of information governance was, why it was so important, and I've listed out a few of the reasons why it's so important on this slide here. Things like, you know, we're moving to an era of access rather than disclosure. And what that means is if you have a viewer, if you think back to the circle diagram that I provided earlier on, in the center of that diagram was a picture that sort of illustrated what a record could look like. It includes information, basic demographics, it includes basic vaccination information, blood types, perhaps some recent events. And that is the kind of screen that can be viewed by many, many people, rather than a doctor saying, hey, I'm going to give you these 5 pieces of information on behalf of Joan Rock. So basically there's a paradigm shift going on. It's more access-based than disclosure-based. And the fact that the whole system will increase the visibility of transactions. In the past, if somebody touched a record in a paper file, you didn't necessarily know that that touch had occurred. However, in an electronic environment, electronic audit trails are built in so that you can see every transaction that has occurred on that record. And we also do expect that there is going to be an increase in trans-jurisdictional data flows. And now people have regularly said to me, look, you know, there's not that many people traveling across Canada. So, you know, if a tourist from BC lands in Ontario and happens to have a health event, is it really necessary that they have access to their electronic record? Well, I just want to take pause here to remind people that there is a lot of other cross-jurisdictional information that gets moved around for purposes other than that. For example, centers of excellence crop up within jurisdictions, or even across jurisdictions. For example, in the Atlantic provinces, not every jurisdiction is undertaking heart surgery. It can very often be centralized in a major center, and that means that patient's information needs to get to the center. If you require this heart surgery, you may need your information to flow to that center from another jurisdiction. There's also many increasing instances where physicians working in one province are actually serving patients in another. A fabulous example was in northern Alberta, where a physician from Nova Scotia had relocated and was providing service to the fellows that are working on the oil derricks up there. But then the physician decided that he was going to move back to Nova Scotia, and the patient said, hey, we like this guy so much that we want to continue to have him providing service. So he agreed to do so, and that has meant that there is movement of information on behalf of those patients across Canada. Now, those are just a couple of examples, and I can give you more, but suffice it to say that we do expect there's going to be continued increase in trans-jurisdictional data flows. So the paper explained why information governance is so important in the EHR context, and it shared lessons learned from other sectors, for example, the finance sector. And one of its key objectives was to stimulate action. It wasn't good enough that that the topic remained buried in Chapter 10 of the Privacy and Security Conceptual Architecture. We needed to have people sit up and take notice and start taking action on it. So some of the key messages in the white paper were on the screen. We realize information governance is not new. It already exists in the paper world. However, from our perspective, it needed to be reviewed in the EHR context because things are different. It also was very clear in recognizing that the jurisdiction's approach will continue to be informed by its own legislation and health delivery mechanisms. So this is not going to be a one-size-fits-all solution. And it also tried to settle people down because, they were saying, oh, my God, we have to start from scratch. Well, there are a number of existing mechanisms in play already in the paper world, and we think that, a lot of that can just be leveraged. And the other thing we were trying to do is settle people's emotions by saying, look, information in the governance doesn't mean, just because we haven't got all the answers, does not mean we have to stop doing the EHR initiative now, because this whole thing is a process. Very often, if you start something too soon, you don't know what all of the problems are or what the full issue is, and you end up creating something that will have to be changed in the near future anyways. So sometimes, that old Japanese saying, better late than early, comes into play. So at the same time, our stakeholders were not really happy with us because here we had released a paper that set out issues, questions, but no answers. And they said to us, look, give us a hand in addressing these issues because they are being faced by all jurisdictions in Canada. And then we also had the oversight community coming to us saying, we really need to be involved more in this initiative. We need to have a better understanding because this is a huge sea change that's happening, and we need to better understand it. So we put on our thinking caps and came up with an idea of creating a privacy forum. So with the support of all of the deputy ministers across the country, as well as all the privacy commissioners and ombudsmen, we created the privacy forum. It includes a representative from each health ministry and each commissioner or ombuds office across the country. Its objectives are to enhance the group's understanding of the EHR, to share experiences and expertise, and to consider information governance issues raised in the white paper and common solutions that support the interoperable EHR. So we got that group underway, and it became very clear very quickly that we would need to create another group, which was going to be focusing really on developing the solutions. So we created this other group called Health Information Privacy Group in 2008, and it is really the group that is working towards developing these common solutions. And with that, we now head into the Common Understandings paper itself. The paper represents the consensus of the Health Information Privacy Group. It builds on existing legislative landscape. People were saying to us, geez, can't you come up with something creative? But the essence is it takes a long time to develop legislation. So we figured that since we're facing the EHR initiative now, we need to play with the cards that we are dealt. So we are building on the existing legislative landscape. It emphasizes, again, jurisdictional responsibility because those are the bodies that are ultimately responsible for making decisions on how they are going to approach health delivery, the EHR system, and privacy. But what we want to do is to promote some consistency in approach. And we wanted to ensure that everything that was in this paper supported trans-jurisdictional flow of information. So we really viewed it as a forward-thinking paper. We had to limit the scope that we were focusing on. So what is in scope is information movement for care and treatment and some secondary uses. But we did not have the luxury of time to deal with huge topics such as public health surveillance nor First Nations. The common understandings relate to 5 basic areas. There are some foundational understandings to start off. Then we focus on trans-jurisdictional collection and disclosure of EHR information. Then the patient control of their EHR information. Then we dipped our toe into transjurisdictional disclosures for secondary use and accountability for information governance. And I'm going to drill down on each one of these sections. In relation to the foundational understandings, these were really aha moments when the group first arrived at them, even though now when we look at them, they go, oh my goodness, this is motherhood and apple pie statements. But even so, we thought that they were really important to set out in the document. There are 6 foundational understandings, but I'm only mentioning 3 on the screen. One of them is that there should be jurisdictional support for appropriate and privacy protective transjurisdictional disclosures. And I say this sounds like motherhood and apple pie now because it does. But when we started, I can tell you, around the table, it wasn't so simple. There were jurisdictions that would say, look, I'm not sending any information out of our province because blah, blah, blah. So coming up with this agreed to position that, hey, it is appropriate for information to move from one jurisdiction to another in appropriate situations was a landmark statement. Then we also needed to be very clear in the paper that recognition that jurisdictions make EHR system choices that meet their legislative requirements while striving for pan-Canadian interoperability. And EHR disclosures must take place in compliance with those legislative or other authorities. Now, why do we need such basic statements? We needed to be clear that disclosures for care and treatment and secondary uses were already happening and needed to be sanctioned or supported in the EHR world. They're already happening in the paper world, and they need to be supported in the EHR environment. And the work of the paper also needed to recognize the varying state of health information privacy legislation across the country and the differing provisions that exist in each of those pieces of legislation. A National Health Act is a really nice idea, but it is eons away. I suspect I'll be retired before that happens. In any case, and we also needed to be clear that even though there is support for information to move across the country, it must be done so in a way that complies with existing legislation. So now let's move to the second type of common understanding, and these had to do with the trans-jurisdictional disclosures and collections. There's 5 common understandings in this section. Now, just a little backdrop here. When people were speaking of the interoperable EHR vision, in the next breath, we would often hear the phrase, the right information to the right people at the right time. And people would also use words like, well, the information is flowing to another jurisdiction, or we're just sharing it, or we're just viewing it. And there were also situations where clinicians would say to us, well, I looked at it, but I don't really want to use it. So what do all of those kinds of transactions mean? In the interjurisdictional context, it was particularly confusing, and we had many heated debates until it became clear that really every movement of information across a border, and you can probably say so within a border, is a disclosure from the first jurisdiction and an indirect collection by the second jurisdiction. People can use words like flow and share and view, but in essence what's happening is the custodian of information in one jurisdiction is disclosing personal information to another jurisdiction. And as soon as it's received by the second jurisdiction, and we don't care how it's received or looked at or whatever, it is an indirect, electronically, it's an indirect collection in that second jurisdiction. And once we arrived at this really fundamental common understanding, a lot of other issues started to become very clear, and the discussion around the table became a little easier. Things like who is accountable and what information do systems need to collect in their audit logs all of those topics started to become a little more clear once we had this basic understanding pinned down. Now, the first understanding led to the next one's on this slide. And that is that the disclosing jurisdiction must follow its legislation and policies respecting disclosure, and the jurisdiction that is indirectly collecting the information must follow its legislation policies for collection. And in addition to that, the information being disclosed to the second jurisdiction becomes subject to the legislation and policies of the second jurisdiction. Now, if there's some lawyers sitting around the telephone right now, they're probably shaking their heads going, oh my goodness, this is just basic. But I'll tell you, a lot of the people involved in this work are not lawyers. And these principles need to be clearly stated for all of the kinds of people that are involved in this initiative. So these two these two common understandings did that. Yes, just let me catch my breath. So the other thing that these two common understandings do is recognize that jurisdiction laws do not extend beyond the boundaries of the jurisdiction. So the third section, or the third grouping of common understandings had to do with patient control and notices. The group spent a lot of time discussing patient control of their personal health information, and particularly the masking of that information, and on what should be in information notices to patients about EHRs. We ended up with 5 common understandings on these subjects. And again, I've only put a few on the screen. So this one reads that the control a patient has exercised over his or her information in the home jurisdiction should be respected in another jurisdiction to the extent possible, given the second jurisdiction's legal framework and EHR system choices. And what that really means is that if a patient has masked information in their home jurisdiction, then it can only be masked in the second jurisdiction if that second jurisdiction has the capability for masking and is aware that the original information was masked. So there are a number of conditions that need to be in place in the second jurisdiction. And the patient needs to be aware or made aware of the fact that, once the information moves on, it may not be possible for that second jurisdiction to apply the same controls or benefits that was in place in the first jurisdiction. And it's not that much different than, people moving from province to provinces with different motor vehicles regulations. I can make a right-hand turn on a red light in Ontario, but as soon as I cross the border into Quebec, I can't do that anymore. So you just learn to see that as a fact of life. And we thought that what was most important here was that every effort be made to accommodate the patient's choices in the first jurisdiction. And where it's not possible, let's be upfront with people and tell them. And we figure if that's the case, then we will probably be in pretty good shape. The other thing we realized is that not all jurisdictions, that the patient notices need to include as well messages about situations in which a patient's information can be unmasked without their consent. People they have a right to know that, you can mask certain things in your record, but you have no right or authority to mask things which are authorized in legislation. And that there may be provisions in place that override an individual's personal masking request. And finally, we thought that patient notices needed to include a statement to the effect that if the individual is seeking care in another jurisdiction, the information collected in that other jurisdiction is subject to the other jurisdiction's masking policies once the information lands there. Oops, sorry about that. Okay, the fourth area had to do with trans-jurisdictional closures for secondary use. As everyone probably around this table knows, the current legislative framework in most jurisdictions authorizes a whole whack of secondary uses. And the common understandings we have recognize that. The other thing is that, I can point to many commissions, the Romano Commission, the Kirby Commission, and other documents that reinforce the value of EHR information for secondary uses. Our perspective around the table was that the EHR environment needs to continue to support existing disclosures of information for secondary use, but that we need to do so in a privacy protective manner. We also recognize that there are many people already working on the secondary use area, so we had to determine what area we were going to focus on. What was it that the Health Information Privacy Group could contribute to? So what we were focusing on were trans-jurisdictional disclosures, disclosures that occurred without consent, that were of EHR information only, and that was identifiable or potentially re-identifiable, and used in the course of clinical program management, health system administration, or research. Now, further, again, secondary use is huge. So what we chose to focus on was de-identification of personal health information, review and assessment processes, patient notification, and governance. The common understandings we arrived at here were basically that disclosures, when they are going to occur using EHR information, the default position should be aggregate information or de-identified information as the norm. But we recognize that there are authorities for disclosures of identifiable information. So even though you recognize you can disclose identifiable in some circumstances, the default position should be aggregate or de-identified as far as possible. We also are saying in the paper that there needs to be an understanding that entities that are responsible for this huge amount of information that's going to be collected need to be relatively professional. I shouldn't say relatively. They need to be professional, and they need to have a knowledge of de-identification techniques that are out there and how to apply them. We actually commissioned a paper that was done by Ross Fraser and Don Willison on de-identifications that are currently available in the world right now. And that paper is referenced in the Common Understandings paper, and I believe we are providing the link after the session as well. So the paper identifies, various de-identification softwares that are out there, and they aren't simple pieces of software. They involve a fair bit of expertise. So we think that the entities that are responsible for managing all of the information that's collected in these EHR repositories need to be professional and capable of handling these sophisticated software solutions. We also recognize that de-identification alone is not enough, and that other practices are required to minimize privacy risks. And again, we commissioned a paper. This one was done by Dr. Khaled and Dr. Elamam Khaled. Anyways, sorry about that. And that there are tools out there that should be incorporated along with the de-identification tools to minimize privacy risks. Yes, so, and continuing in that frame of thought, jurisdictions need to have review and assessment processes in place for trans-jurisdictional disclosures for secondary uses. And we also believe that the review should be commensurate with the potential risk level of the disclosure. Let's face it, if you're disclosing truly aggregated, de-identified information, your potential risk is lower than if you are disclosing something which is de-identified but highly potentially re-identifiable. In the secondary use area, we also believe that patient notification needs to be considered, and that patients should be advised that there are trans-jurisdictional disclosures going on for secondary use, and that we should be able to inform patients on request of what trans-jurisdictional disclosures have occurred in which their identifiable information has been released for secondary uses. And we also include a couple of common understandings having to do with governance related to secondary use. First of all, we said that the foundational principles in the general part of the paper also apply to secondary use. And we also added another item here saying that we, in addition to those foundational principles, think that there need to be information sharing agreements in place for additional protection and clarity. And finally, we ventured into the area of accountability for information governance and interoperable EHR. We see accountability at 3 levels, basically. There's jurisdictional, organizational, and pan-Canadian. At the jurisdictional level, I mean, really this is the ministry, the provinces and territories. As I've mentioned a number of times already, the jurisdictions are accountable. And we assume in this paper that jurisdictional governance structures will be in place or become in place. What we're saying in the paper is that whatever structure the jurisdiction chooses, we think that it's really important that it include a privacy and information governance component. And we ventured into, provide some suggestions for how this could be structured. But we also thought that whatever structure was chosen, that it had to be accountable to the minister, and it needed to be clear where accountability actually resides. At the organizational level, we really didn't spend much time on this because that is totally within the jurisdictional responsibility area. We just basically said that, all the organizations that are within a jurisdiction probably need to revisit their privacy responsibilities in the EHR environment to ensure that they are compliant and meet their privacy obligations. What we really focused on in the paper was the thought that there probably needs to be some kind of pan-Canadian coordinating structure to address, discuss, coordinate common privacy and security-related information governance issues on an ongoing basis, because we don't think that these topics are going to go away. And if by chance they do, there will likely be other ones that crop up as we become more informed and have more experience with the whole EHR world. So what we suggest in the paper is that because we have the Health Information Privacy Group already functioning and looking at these topics, that until somebody comes up with another plan or another approach, we will continue our work on these common issues. So with that, this basically ends the content part of the presentation. Just to let you know that the paper is posted It is being shared broadly through both print and presentations. We have done multiple presentations on it, and we have also released a couple of articles discussing the common understandings. We've had a lot of positive reactions to date. People saying that it's, even though when you're involved in actually writing these things and you sit back afterwards and go, my goodness, that looks like motherhood and apple pie, we've actually had a lot of people who were not involved in the process say to us, these are very valuable and helpful statements. It helps them in preparing information sharing agreements because they understand the basics, principles under which the jurisdictions are looking at the flow of information across the country. We've also had comments from jurisdictions that the paper has already been valuable as they have moved to develop privacy-specific health information privacy legislation. So that's been great. And we've also had considerable interest from organizations and programs that are really involved in interjurisdictional movement of information. Organizations like Public Health Agency of Canada, program areas like the Federal Healthcare Partnership that deal with Veterans Affairs information and Veterans Affairs and the Forces information, and they're looking at information moving across all kinds of jurisdictions all the time. So there's been a lot of positive reaction to it, and we are, right now, what the group is doing is starting to focus on a couple of areas that we didn't get time to deal with over the past couple of years. So with that, I realize we are a little bit late, but I apologize, and be very happy to take questions.
Okay, so just for all the participants, you should see a screen on, a chat box on your screen right now. Please type your questions in there, and then Joan will be able to see them and respond to them.
Okay, I have a question here, but I can only see part of it, Khaled.
If you click on it, Joan, it'll show up on the side.
Excellent, thank you. Slide 21. If the receiving jurisdiction does not have the same controls as the sending jurisdiction, for example, lockbox, what notice will patients get regarding the protections provided at the receiving jurisdiction? So, good question. We, in the paper, suggest that there needs to be a mechanism for people to access first two parts to the answer. We think that there needs to be a mechanism in place so that like a clearinghouse, so that it has sort of the lay of the land for EHR functioning in each province across the country, so that patients can go there and see what the situation is in another province if their information is going to move to another province. So first off, we hope that that's in place. Secondly, we do think that the notice that patients receive on a regular basis should include just a note that be careful, well, not be careful, but be aware that once your information moves to another jurisdiction, it may not be subject to the same rules, just so people have a heads up on that. And I should also mention that even though that's what we think needs to be in place, it's not in place yet, number one. Number two, even though we know and have identified elements that should be in good patient notices, it's going to take a while for all the jurisdictions and all the organizations within those jurisdictions to reach that standard. So as I said at the beginning, it's a work in progress. Okay, here's another question. Slide 20, cross-jurisdiction disclosure. Who ultimately bears responsibility in the event of a misadventure? The original custodian that disclosed the information, the receiving custodian, or both? Good question. I don't know. This is a topic, actually, that we, not a topic, but this is one of the areas, cross-jurisdictional breaches, that we think needs to be discussed and further. So we are currently focusing on that area in the HIT group. Perhaps after another 2 years, I'll have a better answer for you. Question 20, slide 21 again. Does this model presume that the patient will have the ability to provide some level of consent for trans-jurisdictional disclosure? Yes, yes. For example, in British Columbia, we understand that the individual has the right to truly mask information, and there are no overrides allowed. So if you, the patient, say, that's it, I do not want any of that information being shared, then that virtually locks that information, and even if it is requested from another jurisdiction, the information won't be sent. So I think that answers your question in part. Now, you may have other jurisdictions that don't have that degree of rigor, is that a good word, for masking. They will allow overrides to provide care to that individual, so that if an emergency situation and that information needs to be, first of all, there is provision in the jurisdiction to allow an override in an emergency situation. Then that information, if it flows from the first jurisdiction, gets opened by the second jurisdiction, but the transaction at both ends is supposed to be an audit trail will be there indicating that the information was accessed through an override, was disclosed through an override provision. Okay, here's another question. What are InfoWay's next steps with respect to addressing the issues in the Common Understandings paper? There are a number of areas where we would like to drill down a little bit further to actually support implementation. A good example is the patient notification area. As I said, the paper right now says that there should be the clearinghouse in place. Well, it would be nice to actually create that clearinghouse. The paper says that it would be nice to have patient notifications that include X, Y, and Z elements. We would like to actually create templates so that they can be used and customized by the jurisdictions. So that's one thing we're doing. Another thing that we are doing is focusing on topics we didn't get a chance to address the last time around, specifically breach protocols and audit trails. Right now what's happening is that we are getting huge transaction logs being created with the existing systems, and the jurisdictions are looking for some kind of common way of approaching these. You know, what triggers should be, what should we have as triggers for an audit of those transaction logs? How long do we keep transaction logs? What kind of patterns should we be looking for within those transaction logs? So that sort of thing. So we're focusing on specific topics, and we are looking at further ways of drilling down into the work that we've already done. So Khaled, with that, we're looking at 105. I don't know what kind of a arrangement you have here for time.
I think if you're happy with if there are any other questions you want to answer, I think there are only a couple more left. So if you want to take those, then we can wrap it up.
Scrolling down here. Here's a question. Is there a listing of all the interjurisdictional data exchanges that have been considered or assumed? Oh my goodness. It'd be helpful to see how extensive these are and what kind of information is involved. Well, you could probably create a whole career out of pulling that together. So I'm not aware of an exhaustive listing of all the interjurisdictional data exchanges that have been considered or assumed. Okay, when it comes to secondary uses, who will determine which organization gets which information? I don't know. That hasn't been part of our discussion. I'm assuming that that is a discussion that will have to take place at some level. I understand that CIHI is doing a fair bit in the area of secondary use as the EHR. So perhaps that's a body that would be considering this. I don't have an answer. And one final, I missed the description of the clearinghouse. Can I impose on you to describe again? What we were thinking was this. Patients need to be or have some opportunity to understand what goes on in other provinces in relation to keeping their health information private. And we don't think that it is appropriate to expect care providers who are there to be providing care to us, it shouldn't be put an expectation on them to provide that description to a patient. So there probably, this could be a great use of the web, there would probably be a really fine solution here by creating a website that would have these kinds of descriptions in it.